surgical management of acute chemical injury. So you can see here, this is almost into your very advanced grade according to Duva's classification. I'm not playing the PPT with all because that's all textbook material which you could always go and read anywhere here. So here is almost an unedited case which I'm playing for you here. A very large area of epithelial defect. The cornea is severely damaged over here. You can find a linear defect about 3 to 4 millimeters in breadth as well, extending from one. And there is an extensive limbal stem cell affection as well here. So in this case, we have this patient has already been on medical management for a significant period of time, and now to enhance the surface epithelial healing, we are taking them on for an amniotic membrane transplantation here. So the surface is quite inflamed after you've initiated medical management, after you've given a course of antibiotic therapy here. So here we are proceeding with putting on an amniotic membrane for this patient. So it's going to be an amniotic membrane overlay. And what you probably did not see here is there is a lot of symboliphron here in the superior part, which is all attached to the lid here. Had to be separated before the speculum was inserted here. So the membrane is now taken out, fashioned onto the ocular surface and sutured onto the edges. All necrotic material has also been debrided here, and it's being sutured onto the edge of the conjunctiva, from which the conjunctiva is near normal here. Remember, when you're suturing amniotic membrane tissue here, do not put in radial sutures. If you put radial sutures, the sutures will cut through your amniotic, and the very first day post-op, you will find the membrane is hanging loose, and then you will have to take the patient back to the OR, and that sometimes is quite embarrassing as well. So I always follow the technique of putting circumferential sutures here. You can also put continuous circumferential sutures or continuous knotted sutures, mattress sutures, like as you would do in a trap surgery for better fixation, in case it's a large area to be done here. So here you find that the suture, the amniotic membrane, and again, if you are getting amniotic membrane from different sources, ensure that the tissue you're getting is a large sized one. If you get small ones, then it becomes really difficult in filling up the defect which is left over, and you will have problems well. So what I tend to also do is get such a large one, so you find over here the membrane can be bent upon itself and can be used for lining the inner surface of the lids as well. So the margins of this tissue, the edge is now sutured onto the inner margin of the upper lid as well. And then when you put one fornix formation suture and put in a symboliphron shell inside, that likely helps you to layer the entire membrane across the entire ocular surface. And after doing a few number of suture fixation, you can put your glue underneath also if you want to fixate it with an additional glue fixation as well. So this surgery does take a long period of time, and always I use minimal cautery. Before starting, what I do is adequately pack the surface with adrenaline soaked swabs here. So I have plenty of thin cotton wicks soaked with an adrenaline, and I place it on the ocular surface, so that helps to control the bleeding as well, and thereby you use minimal amount of cautery. So 2 or 3 things here: optimize the surface with optimal medical therapy, see that there is no surface inflammation, infection, so antibiotic treatment is done on the surface here, and try not to do too much of cautery for this person, for these eyes, and cover all the bare epithelial surface, both conjunctival and the corneal surfaces, which are all lying bare of epithelium, should be aptly covered by your amniotic membrane here. So this is being an unedited video almost, so which I'm showing here. So I'm showing a continuation of this. The membrane is almost put into place here. Much of it is sutured. If you have extra membrane, sometimes I go ahead and instead of doing with a single membrane, I go and do 2 membranes also. So it becomes a bi-layered or a multi-layer technique, so that this allows the membrane to stay on the surface for a long period of time. So you can see this is very well positioned here. So I put in a double-layered membrane over here, covering the entire region of epithelial surface damage here. And what you need to follow this up on follow-up is, along with antibiotics, minimal steroids, adequate lubricant therapy, vitamin C, and sodium ascorbate drops here. You can also supplement with oral vitamin C for these patients along with doxycycline. And sometimes you will have to take these patients back into the OR once the membrane is melting faster to do a second episode of amniotic membrane as well. So here you see I've already put in, and I'm trying to position with a little glue. Sometimes with multi-layer, the glue usually doesn't stick on to the surface very well. But if you're doing a single layer, that can help you to stick on. So here you can see the mishap. The glue was not formed very nicely here, so it's already clotted instead of spreading out evenly here. And it's rather complicated the entire scenario, and where I'm going in, removing out the knotted material. So again, sometimes what we tend to do in the OR is there's something left behind on another OR, and to optimize, and this is a poor patient who's not bought the tissue, and the staff gives us the vials just like that without letting us know, and what is clotted in the cannula then gets pushed inside. So these are all errors which tend to happen time and again, so probably you can take care of those as well and finish up your surgery and put a symblepharon shell there and keep these patients under close follow-up. Another particular factor which is important in these is when they tend to put drops, when you're using symblepharon shells, there's a central opening which is commonly present. And patients tend to fill in their steroid drops exactly in that region. So I've seen a couple of patients here where the steroid keeps acting on, and that itself starts acting as a nudge and starts and sort of precipitates a keratolysis over there. So that's a factor which you also need to take into control. So I tend to call my patients back early and sometimes take out your symblepharon ring, sterilize it again and put in a fresh one here. So these are other smaller tips when you are managing these patients. I think Vinay is going to take on the next ones of SLET along with this. So if we have time, I'll show you one more, otherwise we can we have time. Can you the next folder? Which is the folder, please? Sorry, I closed it, I guess. We can take some questions in the. I want this closed. I want the other folder.
Madam, are you
yes,
using anti-receptor OCT for grading this chemical burn?
Are we using
Anti-receptor OCT
the anterior
for
segment
the limbal
OCT?
ischemia?
No, we still in ours we cannot image the amount of extent of damage, so we still use it to do it using the clinical classifications only in our patients here. And what we use the ASOCT is to look at the amount of corneal thinning which is being present in these patients, especially the lot of haze which is present outlying. We use it to assess the amount of underlying thinning in these patients here. And that is also more useful if you are looking at, I think I won't show the SLED part that Vinay will cover. So this is a chronic chemical injury. So I'm going to show the post-bed preparation here. I'm primarily showing the post-bed preparation because I usually tend to do it in two sittings, where I do the symblepharon management in a chronic chemical injury circulate separately. If it is minimal, as in this case, then I usually tend to do it together. But if it is a case in which it requires a lot of superficial keratectomy and removal of fibrotic tissue, I tend to do it in two separate sittings. So here you can see there is an extensive amount of superior symblepharon here, and there is a significant fornix foreshortening in this region as well, and that precludes the eye from rolling down here. So when I'm going to start, I then look at what is the area in which the limbal stem cells is looking reasonably okay, and here you go ahead, and I have done a 360 degrees peritomy already over here and try to preserve as much of conjunctival tissue as possible. So that's going to be one important key, and do not take away what you want. So once I've done a 360 degrees peritomy and superiorly I've released all the symblepharon with the lids and subconjunctivally as well, I follow this technique of making two horizontal snipes at the 3 o'clock and the 9 o'clock position. Again, here I use minimal cautery, and I do at least 2 or 3 times packing the surface with adrenaline soaked swabs, and that really helps. You might spend about 5 to 10 minutes on this, but that really helps to control the bleeding, gives you adequate hemostasis control here without having to use cautery on these surfaces which are already scarred here. So you could see I've just applied these cotton wick soaked with stoked with adrenaline. And then what I tend to do is make a horizontal snipe here and a horizontal snipe here. That will divide your conjunctival cul-de-sac into a superior and an inferior half and will allow both to fall back, and then you can close the remaining surface with just amniotic membrane here. So that gives you an increased depth of fornix formation and gives you optimal preservation of the conjunctival tissue which is already present on the ocular surface for these patients. And then if I'm doing a slit, I carry on and complete the slit on this patient. So here you see a 360 degrees peritomy. The cautery, the surface is well controlled here. The amniotic membrane is placed on the surface here and sutured on to all the edges of the conjunctiva as I described in the acute chemical injury management as well. Then put in a glue and fixate and allow the surface to heal with adequate antifibrotic therapy here. So this also helps you to optimize the ocular surface before you want to take the surface on for a simple limbal epithelial stem cell transplantation if it's a uniocular case here.